All right, fantastic. And thanks very much for inviting me, and thanks for sticking around. It's quite a posh place that we're in here. It's near my patch, actually. I work as a clinical psychiatrist, and most of my work's been in crisis teams just around here and in up to King's Cross. So a lot of the issues I'm going to talk to you about what what we've looked at with data science, kind of we're always thinking about their relevance to the people that we see with severe mental illness here and of course across the country. So I've brought a few little bits and pieces along from work that we've done over the years that I hope you will find interesting. If I talk about stuff that's too clinical or anyone doesn't understand, please stick your hand up and say, what are you talking about? And but otherwise I'll crack on. Hopefully many of you know that about this huge interface between severe mental illness and various physical health problems. We were talking earlier, I've particularly focused on cardiovascular disease. It's a huge problem. People with severe mental illness die up to 20 years earlier than their fellow people in the general population. And unfortunately, we've known this for a long time, but that mortality gap is increasing. One of the really important things for us to think about in data science is how multifactorial it is. There are obviously lots of issues that are common to the general population about things like diet, physical activity, the stress of having an ongoing long-term severe mental illness. One of the things that constantly comes up are issues related to some of the medications, and I'm going to show you a few little studies where we've tried to unpick this antipsychotic medication problem. And I think when you talk to people with severe mental illness, all the time when we do focus groups, qualitative work, they say, basically, the minute that anyone clinically hears that I have a mental health problem, all they talk to me about is suicide, mental health, hallucinations. Whereas I went to see them about my stomach, I went to see them about a physical health problem, but I just get labelled, and that speaks also, of course, to the stigma of mental health problems. So that is a background that hopefully many of you know. I was introduced to national primary healthcare databases, it's frightening, 20 years ago. This is one of the first studies that we published looking at cardiovascular disease in people with schizophrenia, bipolar disorder, and other psychosis. I mean, it shows you the power of these studies. My PhD, I recruited people with severe mental illness. It took me 2 years to recruit 74 people. You know, here's the power. You know, you've got huge coverage across the UK, and we had 2 cohorts in this study of nearly 50,000 people with severe mental illness and looked at how common heart attacks and strokes were. And I've just brought the headlines. It's a shocking story that people under 50 are 3 times more likely to die from a heart attack or stroke. People aged 50 to 75, twice as likely. And, you know, we grumble about the quality of the data in these primary care records. We were able to do a little bit of picking down statistically to look at this, to think about how much of it is smoking. Well, some of it was, for sure. Some of it was deprivation. We looked at medication, showed that it's not all medication, because people who weren't receiving antipsychotics were more at risk. But also we showed that people who are on higher doses of antipsychotics were most at risk. So there's power in these data to look at some of the causes. And this is just another study. There's a chap who worked with me, Joe Hayes, who many of you may know, who does lots of great data science looking at psychotropic medication in severe mental illness. But this study, again, is kind of 10 years later, and what we found was the mortality gap was going up. And if you repeat the study now, as we have, I'm afraid that mortality gap is still there. So in some ways, depressing, but something that we obviously need to really look into. And I've brought, as I said, a few little studies about antipsychotic medication, just to talk about not only the power of the data that we have, but also some of the methodological challenges. Again, when we talk to people with severe mental illness, over and over again, they talk to us about, well, what's the impact of the medication? And the thing is, of course, the gold standard is to do a trial, but many of the medication trials are 12 weeks. If you're lucky, maybe 12 months follow-up. Cardiovascular disease accumulates through our lives, and we're really talking about people who have long-term conditions. So really, we ain't going to get trials, and so we have to see what we can do with these rich data sources that are available to us. And I'm just going to show, I'm probably only going to show you one, I think, study that we tried to do, but I like to put this this study up just to emphasize the kind of the battlefield that we're in, if you like. This was in the BMJ. It's probably 10 years old. I can't, 8 years old. With a picture about the magic of a randomized control trial, because basically we flip the dice and we have no idea whether this side are going to go into treatment A or treatment B. And as you all know, the magic of that is that what it does, all the things that I can't measure about you, I don't know whether you watch soap operas, whether you secretly go out dancing, whether you whatever, all these things, it magically distributes them. And so you take away this problem about bias when you analyze people's response to treatment. But we can't randomize necessarily in our longitudinal data. And I just thought I'd show you this study, really important study, because everyone talks about the weight gain on antipsychotics. Some of you may not be clinical, so I just say these are the 3 most common antipsychotics that we prescribe in the UK: risperidone, olanzapine, and quetiapine. And they all have the potential to cause weight gain. But the big question, of course, is which ones are worse. And so here, look at the power of this study. Huge numbers of people who are taking a single antipsychotic. And we were able to follow them up in the THIN database, which is just another one of the primary care databases. And we found that there was plenty of measurement of weight for us to be able to assess this over 2 years, and which people did better and who did worse. I hope you can see this. This is basically the 3 drugs. Risperidone is blue, olanzapine is red, and quetiapine is green. On the whole, people would tell you that the most problems with weight gain occur with olanzapine. And this is kind of interesting. What you can see is this is baseline before people receive antipsychotics. Follow them up over 2 years, and the average weight is going up. This is the women, and it kind of looks like quetiapine is the worst culprit here. But look at the problem. The problem is at baseline. And at baseline, in fact, I mean, it's a good news story in some ways. Olanzapine is the one we're worried about. And in real life practice, people with olanzapine start off with the lowest weight. You could call it confounding by indication is the posh name for it, which is maybe good that the clinicians are not giving olanzapine to people who are more overweight. But what starts happening is actually the olanzapine folk, despite being having less weight at the beginning, they catch up. It's similar with the men, olanzapine at the bottom, everybody gaining weight and olanzapine catching up. So even though you prescribe it to people with lower weight, they're actually gaining more weight. And just to summarize that, I haven't brought all the comparative statistics, but far more significant weight gain over 2 years compared to risperidone. And there are guidelines out there. So this has influence, and there are guidelines for what to do to try and prevent this problem. I'm turning to, so that's something about side effects. I'm going to turn just to the other side of it, which is what can you do about physical health and cardiovascular disease in people with severe mental illness. I'm going to embarrass somebody now because Ruth Blackburn, hi Ruth, Ruth did a PhD with us, part of our Primrose physical health program a way back now. And we were interested in this question. People say, well, actually, statins are there to prevent cardiovascular disease and lower lipids, but do they work in people with severe mental illness? Some of the perhaps stigma from clinicians might say, oh, well, they've already got too many medications or they won't take them or what have you. So Ruth, not me, designed, this is a lovely thing about designing different methodologies. And Ruth did this, what was called a staggered cohort study, where you chop the data up and chop it up into, tell me if I'm saying this wrong, but chop it up into periods when people are taking a statin and people when they aren't. You do all these staggered cohorts and you're able to adjust for confounders and see whether the statins, periods on a statin really do bring cholesterol down as you would want them to. And this, again, Ruth's PhD into 2 slides, is that we were seeing in real life, using these real life data, that actually they do work. Statin use did bring down cholesterol in people with severe mental illness. So they were taking it. It was effective despite all the other challenges and other medications people have. And really, you are decreasing cardiovascular disease. So powerful methodology, interesting result. I don't know whether you believe me about this one. I like showing people this study, which is a kind of different way of thinking about statins. You're aware that there's lots of noise about inflammation in mental health these days. And Joe Hayes, again, led this study in Sweden, saying, okay, well, we know that statins work for physical health. If they're anti-inflammatory, as are these drugs called calcium channel blockers and metformin, maybe they might have psychiatric effects. Again, very hard to do a trial. And Joe did a different methodology here. He did something called a SelfControl K Series, which is quite clever because you use, say, me, and a time when I'm taking the statin, and then you use a period when I'm not taking the statin and compare them. So because I'm probably quite similar when I'm taking it and when I'm not, maybe, then I'm acting as my own control. So long story short, it's a very interesting study that showed that when people were prescribed statins, they were less likely to have a psychiatric hospitalization, less likely to self-harm. And that was true also for metformin, as well as for calcium channel blockers. So it's interesting, and has always interested me about this interface between mental health and physical health. Any cynics about it? Go on.
Well, there is a point, an age at when you are prescribed statins.
Yeah.
And you might well be older at that point.
Yeah.
You also might have better management of your serious mental illness by the time.
Yeah. Yeah, absolutely. So is it that when you're prescribed and taking something, actually you're just getting more healthcare and you're doing better? He did something clever, which was have a dummy drug, which was a diuretic that doesn't have anti-inflammatory properties. And we did not see this effect with the dummy drug.
Oh,
so, but interesting. So, all right, we've talked a bit about statins. I'm just going to go and talk. Naomi Launders was a PhD student with us trying to use the latest versions of CPRD, not as big as the British Heart Foundation stuff that we heard about earlier, but using GOLD and ORAM data linkages actually to try and look at multiple long-term conditions. 2 minutes, I'll try. Naomi's now working with us on datamind, actually, which is exciting, and she got her PhD last month, so I'm stealing a bit of her work just to show you some headlines that we've found there, where we've been trying to bring everything together in physical health, thinking about multiple long-term conditions, not individual comorbidities. And this is a terrible graph, but essentially what Naomi's showing is this is when people receive their diagnosis of SMI in primary care, and all these blobs on the right show that people already have a whole host of conditions that are diagnosed before they have SMI. And there's some examples there just showing each of these graphs. For instance, diabetes, this is when people get the diagnosis, and you can see it accumulating before and after. So there's plenty of opportunity that we've learned from data in order to intervene. She also showed that people had far more emergency physical health admissions. These are called unplanned admissions, using the linked data, showing again, it looks like prevention ain't happening out there for these detectable long-term conditions. And perhaps I will just speed up and just say one final thing from her work, which was you can't treat everybody the same. And there's something really important in our work about thinking about differences between individuals rather than grouping everyone with SMI together. And there's a particular pattern that she found with people who receive a diagnosis of schizophrenia, particularly being far more likely to die earlier and receive inferior care compared to other people with SMI. All right, so I promise you I've only got 2 more slides. I mean, I think, you know, what have we done with data science? It is true that the physical health of people with SMI has got itself onto Public Health England, now OHID radar. We've got fingertips data regarding mortality across the country. It's been part of the quality outcomes framework in primary care. For ages, it's part of the obligations of integrated care systems that are all coming into play now in NHS England. So we know we've got to do better. We know we've got to prevent things. There are a few examples there of things that we've been doing, and we have a programme that we've been rolling out in Camden and in Bradford at the moment to improve this management. But just some thoughts from me, really, that I'm happy to take questions on from people, perhaps given we've run out of time. But I think the PPI is just obviously so central, and we had a brilliant session earlier from PPI colleagues. Our electronic health records are great, but we just have so little data in there. And Kathy's talked about our aspirations. How do we get data on sleep or data on lifestyle or all manner of things that really underpin much of the risk of developing long-term conditions? I worry about unrepresentative samples, that many people don't take part in trials or cohorts, so we don't see them. And that, I think, is enough for me.
Thanks very much, David. That was a fantastic talk and presentation. Just to pick up on your first point there about PPI, I wondered if you've done any research to understand what the priorities are for people with SMI. What would they prioritize in terms of research questions, and what data science might be able to answer?
We've tried to do quite a lot, actually. It's interesting, and Dan is here from McPin, and we have a data science PPI group that we work with, because it was interesting learning over the years about how, you know, we can talk in terribly complicated ways that are then excluding to people. And we have a group who are, you know, they're versed in things like cohorts and compounding and adjusting and stuff like that. But I mean, in truth, we have done a lot of work with service users. It really does often come down to the medication. People are also interested in stigma, in siloed care, is particularly something that's come up. Dan, can you think of other things? I mean, particularly side effects often comes up of antipsychotic medication.
My experience, and this is sort of going back a bit rather than the work that we've done specifically with you, this idea of personalised medicine, wouldn't necessarily use that term, but kind of, is this medication going to work for me, or are you just throwing medications at me randomly to see which one sticks? So anything that can fast track that process.
Thanks, Dan.
Thanks. No other questions from the floor? Yeah.
Hello. This is a bit of an end question, but like, you know, you talked about impact of, you looked at, like, you know, the effect of on physical health. What about the effect of physical health on mental health, and what are the larger data sets for that? Have you thought about that?
Yeah, good question. I mean, we've thought about it a lot, and you're absolutely right. Of course, it's a bi-directional thing. And here with severe mental illness, we've often thought about it being a very long-term condition. But I'm sure one of the PPI colleagues earlier was talking about the impact of physical health on mental health. And nearly all, we talk about multiple long-term conditions or multimorbidity now, but mental health nearly always alongside there. So, I mean, you know, the obvious one that I was thinking about when Kathy was talking to us and saying, you know, you have to do cardiovascular research in the centre, is that how can you do cardiovascular research without looking at depression and anxiety, which are really common risk factors and outcomes from cardiovascular disease? And you can tell the same story if whichever disease domain you want to go in. So, no, you're absolutely right. You can, I mean, the problem with CPRD and all these electronic health records is you have to get a code in your notes. And so, I mean, I'm terrible at going to the doctor, so I've got nothing in my record really. So, you know, I might be depressed as anything kind of, but you will never know. So, but at least, you know, those data will tell you who has received a diagnosis. People might have more intelligent thoughts than me on other data sets that might be able to explore those questions.
Thank you. We have a question over here.
Hi, Owen from KCL. I'm just curious about how you take these results from the research side of things and implement them into your everyday work with patients. And so say you see that statin reduces inflammation or olanzapine causes increased weight gain. Do you take these into effect, and do your colleagues do the same, I think?
Yes, well, I think I do. Personally, I think it's a big challenge. I think what I've noticed, certainly the problem with weight gain with the olanzapine I showed you, certainly anecdotally, I think we're seeing far more people are using what's called a weight-sparing antipsychotic, which is aripiprazole. There was some cynicism about whether it is as effective as its predecessors, but I think we are seeing that. I think that said, we still have a massive problem about this mind-body divide. And in truth, many mental health clinical professionals are pretty uncomfortable with physical health interventions. We know that metformin, which is primarily a drug for diabetes, we know that if that's prescribed in people at risk of weight gain, it can help decrease weight gain along with behavioural interventions. It's hardly ever used really in clinical practice because the mental health workers won't start it. And then the GPs want somebody, GPs have got a lot on, but they don't tend to do it either. So I think we've still got a long way to go. And I have some sort of naive optimism that with these new integrated care systems that we're finally going back to saying we've got to work holistically about our mental health, our physical health, but I'm not going to pretend it's a rosy picture right now out there clinically, but, certainly the trainee doctors I work with are much more attuned to this holistic approach. So I think so. But I hope in the future, if they pay them properly.
Thanks. We have time for one last question. Holly, I think that's you.
Hi, I'm currently doing work on looking at physical and mental health of pregnant women. So it's very fascinating.
Yeah.
And obviously the majority of that multiple long-term conditions are having more than one mental health condition when they enter pregnancy. That's a separate thing. I just wanted a real practical thing that comes from your work, and it seems to me quite strange that it's not there. When you get to a certain age, you have a health check that tells you your 10-year risk of having a heart attack. Do you think that whether you have a diagnosis of a serious mental illness should be added to that Q-risk calculator based on the evidence that you've shown me today? And indeed, if you're taking certain antipsychotic medications?
It's a really good question. I could really bore you about this because we did do a whole load of work trying to do a 10-year heart attack risk predictor for people with severe mental illness. Long story short, severe mental illness is in what's called Q-risk 3, which is the last iteration of the 10-year tool that GPs use to predict heart disease. Unfortunately, or fortunately, they defined severe mental illness very differently from how we usually do because they included everybody on the depression register in it. But nevertheless, it is in Q-risk 3, as is having an antipsychotic medication. So it probably came out about 4 years ago, Q-risk 3, but getting it into practice, I still don't think it's there. So people are at the moment using Q-risk 2. I'll tell you one more tiny bit of when I was doing my PhD and looking at 10-year risk scores, you'd see somebody who was 30, had bipolar disorder, was overweight, was a smoker, but their 10-year risk is tiny because actually you don't have heart attacks at 30, you have them at 40 or 50. So giving somebody a 10-year risk score underestimates their risk, and you just need to really not just go by that, but intervene really early for people, as Naomi's work shows.
Thank you. Did you want to make a comment there? Or it was
same point.
Okay, thanks very much. We're at the end of the session, so please join me in thanking David for